Welcome back. Today, we're doing something a little different. We're not just learning, we are putting your clinical reasoning to the absolute test with a board-level quiz on hematology. Ready to see how you stack up?
And that quote really sets the stakes, doesn't it? It highlights that in medicine and dentistry, truly understanding these markers isn't just academic, it's a fundamental part of keeping patients safe. Okay, let's dive into this. So here's how we've broken down the challenge. 5 rounds, each one hitting a critical area of hematology. Let's see how you do. All right, let's kick things off with round 1. This is all about the fundamentals of red blood cells. Pay close attention to the clinical details here. First question. A 28-year-old female has angular stomatitis and a sore tongue. Her full blood count shows a low MCV of 74. Which of these is the key finding in the early stage of her condition? Is it A, B, C, or D? The correct answer is B, falling serum ferritin levels. Here's why that's so important. In early iron deficiency anemia, the body's iron storage tank, which is what ferritin reflects, starts to empty out before you see a major drop in hemoglobin. It's the first domino to fall.
Question 2. Okay, we know red blood cell production, or erythropoiesis, is a reaction to low oxygen. So, what's the correct hormone and where does it come from? The answer here is B, erythropoietin released from the kidney. You can think of the kidneys as these incredibly smart oxygen sensors. When they detect that oxygen levels are dipping, they send out the hormonal signal, erythropoietin, that tells the bone marrow, hey, we need more red blood cells, stat.
Last one for this round. A patient with chronic renal failure has an MCV of 85. How do you classify this anemia? The answer is C, normocytic anemia. The key number here is 85. That falls right smack in the middle of the normal range for red blood cell size, which is 79 to 98. So the cells aren't too small or too big, they're normal-sized. This is a classic presentation for anemia of chronic disease. On to round 2. Now we're digging into some critical vitamin and mineral deficiencies, the kind that often show up with telling signs in the mouth.
Question 4. A 45-year-old woman with glossitis and dysphagia, which points towards Patterson-Brown-Kelly syndrome. What lab finding is going to nail down the diagnosis? The answer is B, depleted bone marrow hemosiderin stores. This syndrome is all about severe, long-term iron deficiency. The most definitive way to prove it is to look at the bone marrow and see that the iron stores, called hemosiderin, are completely gone.
Okay, next up. A 62-year-old has a burning tongue and that pins and needles feeling, suggesting pernicious anemia. What's the most consistent finding? The correct answer is A, autoantibodies against gastric parietal cells. This is such a critical distinction. Pernicious anemia isn't just about not eating enough B12. It's an autoimmune disease. The body's own immune system is attacking the cells in the stomach that are needed to absorb vitamin B12.
Last question of round 2. Let's talk about the nitty-gritty of iron absorption. Which of these statements is most accurate? The answer is C. Gastric acid converts ferric iron to ferrous iron. It really all comes down to a little bit of chemistry. The iron in plant-based foods is in a form our bodies can't easily absorb, the ferric or Fe3+ state. Stomach acid does the crucial job of changing it into the much more absorbable ferrous or Fe2+ state. And now for round 3. These questions are all about inherited disorders, where knowing the triggers and the right way to manage them can literally prevent a disaster.
First up in round 3, a patient with a known sickling disorder needs a tooth pulled. To prevent a crisis, which pain medication is a huge no-go? The answer is B, high-dose aspirin. This is a massive patient safety issue. High doses of aspirin can push the body into a state of acidosis, which is a powerful trigger that can cause red blood cells to sickle and lead to a life-threatening crisis.
Question 8. When you're using conscious sedation on a patient with sickle cell, what's the absolute minimum oxygen you need to provide? The correct and crucial answer is C, 50%. You have to give at least 50% oxygen throughout the entire procedure. Low oxygen, or hypoxia, is the other major trigger for a sickling crisis, so keeping that oxygen saturation high is non-negotiable. And to wrap up the round, what's the best description of how sickle cell is inherited and how it works? The answer is B. Sickle cell is an autosomally inherited disorder. At its core, the problem is a single tiny change, an amino acid substitution, in the globin chain of hemoglobin. This one little change causes the hemoglobin to clump together under stress, making the red blood cells rigid and leading to those dangerous blockages in blood vessels.
Okay, let's move into round 4.
We're getting into some challenging territory now, dealing with cancers of the blood and lymphatic systems.
Question 10. Which of these cancers makes up a staggering 85% of all childhood leukemia cases? Is it CLL, AML, ALL, or CML? The correct answer is C, acute lymphoblastic leukemia, or ALL. It is, tragically, the most common form of leukemia we see in children. Next one. A 35-year-old man has swollen lymph nodes in his neck. The biopsy shows Reed-Sternberg cells. What oral health problem is he most likely to face? The answer is B, bleeding tendencies and infection risk. The moment you see Reed-Sternberg cells, your brain should immediately scream Hodgkin lymphoma. The disease itself and the chemo used to treat it can crowd out the bone marrow, which means you can't make enough platelets or white blood cells. This leads directly to a high risk of bleeding and infection. Last question on leukemias. When you're trying to tell the chronic leukemias apart, what's one feature that's way more common in CLL than in CML? The answer is C, lymph node enlargement. While both can give you an enlarged spleen or splenomegaly, having significantly swollen lymph nodes is really a hallmark clinical feature of CLL.
And here we are, the final round. This is where we cover some specialized and high-risk conditions where your clinical judgment is everything. Question 13. You have a 70-year-old patient with polycythemia vera, which is causing hyperviscosity syndrome. Which anesthetic technique do you need to avoid? The answer is B, regional nerve blocks. Hyperviscosity syndrome basically means the blood is super thick and sludge-like. If you do a nerve block and accidentally hit a blood vessel, you're at a much higher risk of causing a big dangerous bleed, or hematoma. Next up, a patient gets aplastic anemia after being exposed to certain drugs. What do their labs look like, and what's the prognosis? The correct answer is B. Aplastic anemia is when the bone marrow just shuts down. It stops making everything. The result is something called pancytopenia, a shortage of all blood cells, red, white, and platelets. And unfortunately, it carries a very grim prognosis, with a 50% mortality rate within just 6 months of left untreated.
And our final question of the quiz. A patient with thalassemia major needs blood transfusions all the time. What's the biggest complication you have to watch out for? The final answer is B, iron overload and potential viral transmission. It's a tough situation. The transfusions are life-saving, but the body has no good way to get rid of all the extra iron that comes with those donated red blood cells. Over time, that iron builds up to toxic levels. And of course, there's always a small risk of transmitted viruses.
And that's a wrap on our challenge. So, how'd you do? Whether you aced it or found a few areas to brush up on, the big takeaway is that this knowledge is what directly impacts patient safety. It's what stands between competence and catastrophe. Thanks for playing along, and be sure to follow for more.